Good morning, everybody, and welcome to this talk of chronic kidney disease in cirrhosis, mainly unexplored area. So this is the outline of my talk. And chronic kidney dysfunction in cirrhosis is a new frontier in hepatology, and we all know that CKD is a major public health problem, and it is an epidemic, extremely common, 844 million people worldwide, and 1 in 10 persons having some form of CKD, and it is going to be the 5th leading cause of death in 2040. And obesity is the main driver of the epidemic, and worldwide prevalence of obesity has nearly tripled since 1975. So what is the magnitude of chronic kidney disease in cirrhosis? The CKD prevalence in general population is 11 to 13%, and prevalence of CKD in cirrhosis 1 in 2005 to 46 in 2019. The rising prevalence of diabetes, hypertension, and NAFLD is the cause of rising incidence of CKD in cirrhosis. And NAFLD increase in SLK transplant from 8.2% in 2002 to 22% in 2011. And atherosclerosis and glomerulosclerosis is common in cirrhosis. And about 25% of the candidates for liver transplant have significant coronary artery disease. The rising prevalence of CKD in cirrhosis, it was reported as only 1% CKD in cirrhosis, while in 2019, 46.8%, and ILBS data 269, that is 32.8% patient, indoor patient of cirrhosis had chronic kidney disease. So CKD in cirrhosis, definition and classification. The renal dysfunction in cirrhosis, the classification and definition is evolving over the past decade and is still evolving. And still we have not reached to the ideal definition and classification of renal dysfunction in cirrhosis. So the criteria for chronic kidney disease, either of the following for more than 3 months, either the markers of kidney damage are present, one or more markers, or decreased GFR is present less than 60 ml for more than 3 months. And as the kidney disease progression, chronic kidney disease increases, and their prognosis is poor. So definition of chronic kidney disease, either AKI, acute kidney disease, or chronic kidney disease. It is in relation to the time. Up to 7 days it is acute kidney injury, up to 3 months it is acute kidney disease, more than 3 months reduced GFR is chronic kidney disease. Then what are the determinants of increasing chronic kidney disease in cirrhosis? Aging population, you know that age, as the age advances, the GFR decreases, and there is high prevalence of AKI in cirrhosis leading to chronic kidney disease, and rising prevalence of diabetes, hypertension, MAFLD, and there is a newer concept of cardiovascular kidney metabolic syndrome, and there is glomerulopathy associated with chronic liver disease associated with hepatitis B and C. So what is the progression of AKI to chronic kidney disease in cirrhosis? The spectrum of AKI in cirrhosis, acute kidney injury, prerenal azotemia, HRS or non-HRS AKI, and HRS AKI, HRS CKD. So HRS type 2 is now known as HRS CKD, and there is a lot of overlapping between these two syndromes. So the prerenal failure and ATN, they are the continuum of the disease. So as the renal ischemia advances, the prerenal failure, volume of challenge, it responds. HRS does not respond to volume challenge, and there may be acute tubular necrosis when the renal ischemia persists. So prerenal failure due to HRS, the tubular lesions may be present. ATN is the consequence of the untreated HRS, and HRS is not always reversible after liver transplant. So the acute kidney injury and CKD as an interconnected syndrome. When the patient develops AKI, he is more likely to go into CKD, and CKD patient is more susceptible to subsequent acute kidney injury. And recurrent acute kidney injury is a predisposing factor for chronic kidney disease. So as the patient advances, GFR reduces, there is much progression leading to dialysis and progression to CKD. So much time is not there. We have to treat AKI, diagnose AKI, prevent AKI, and treat it urgently. So what are the determinants of HRS AKI reversal? So the negative factors are the worsening hyperbilirubinemia, congestive nephropathy, associated volume overload, congestive cirrhosis cardiomyopathy, and the positive factors are increase in mean arterial pressure and control of the acute or triggering factors. So these incidence risk factors and outcomes of transition to AKI to CKD in cirrhosis, prospective cohort study, ILBS study, almost 2/3 of the patients with cirrhosis develop episodes of AKI and reduction in GFR, and 1/3 progress to CKD, resulting in adverse outcome. Higher MELD and cystatin C levels and number of AKI episodes predict development of CKD in patients of cirrhosis. So what is the pathophysiology of kidney disease in cirrhosis? We know the AKI in patients with cirrhosis, it is a unique form of acute kidney injury when there is intense renal vasoconstriction in presence of splanchnic vasodilatation. So the AKI may revert back or AKI may progress to chronic kidney disease. When the repair is adaptive, patient can recover from AKI. With a maladaptive repair, patient progresses into kidney dysfunction and chronic kidney disease. So the CKD in cirrhosis is associated condition and risk factors. NAFLD, diabetes, hypertension, atherosclerosis. CKD may be organic or the structural. While the neurohumoral changes, CKD may be functional, that is HRS, may be reversible by vasoconstrictor and albumin. Then there may be associated alcoholic liver disease, viral disease leading to IgA nephropathy, glomerulonephritis, and cryoglobulinemia. So MAFLD is a precursor of chronic kidney disease. MAFLD can cause chronic kidney disease irrespective of diabetes and obesity. So the clinical conditions associated with NAFLDs, it's a systemic disorder. Multiple areas, multiple organs are affected by NAFLD. So the organ crosstalk in the pathophysiology of NAFLD and CKD. So risk factors are calorie intake, dietary and genetic factors, mutagenesis in PNPLA3 gene, then adipose tissue inflammation is very important. Then NAFLD, NASH leads to CKD. The other factors are the atherogenic dyslipidemia, inflammation, fibrosis in the kidney, increased uremic toxins, and the alteration in gut microbiota is very important. You see, when we eat fiber, it is the food of the microbiota present in our intestine. And these microbiota release short-chain fatty acids, which are very helpful in not only the digestion and the enzyme release, but it increases the immunity. And there is a crosstalk between microbiota, liver, kidney, and brain. Liver-kidney axis in NAFLD, this is a recent concept, the genetic polymorphism, adipose tissue, inflammation, dysbiosis in the intestine, the leaky gut, the myosteatosis leading to peripheral insulin resistance. All these factors lead to hepatorenal reflux. There is increased sinusoidal pressure and there is increased hepatorenal reflux, increased hepatorenal resistance. So even with initial early NAFLD, because of the increased intrahepatic vascular resistance, increased sinusoidal pressure, there is a hepatorenal reflex which reduces GFR. So NAFLD therefore can lead to renal dysfunction irrespective of the diabetes, hypertension. So when the clinically significant portal hypertension and decompensated CKD, the portal pressure is high, it is obvious. But it has been observed that with subclinical portal hypertension, when the HPPG is between 5 to 10, even then hepatorenal reflex was present and the GFR was reduced. So links between metabolic syndrome, NAFLD and insulin resistance. There are fatty liver, inflammation of the liver leading to insulin resistance, hyperlipidemia, inflammation, glucose tolerance, intolerance, obesity, and abdominal obesity. Abdominal obesity is the fat in the abdomen is an endocrine organ. So it increases insulin resistance, leading to type 2 diabetes and cardiovascular disease and metabolic syndrome. Interplay between obesity, hypertension, kidney injury, and so ultimately there is vascular damage, kidney injury, cardiovascular disease, and reduced kidney function. Insulin resistance is very important. Other diseases associated with NAFLD, as we have described, it's a systemic disease. So multiple organs are involved. So the metabolic dysfunction associated fatty liver disease predicts new onset of chronic kidney disease better than fatty liver or NAFLD. MAFLD is independently associated with new onset of CKD and predicts the risk for development of CKD better than fatty liver or NAFLD. Now, cardiovascular kidney metabolic syndrome is a newer concept adopted by the American Heart Association. So the dysfunctional adipose tissue, excess adipose tissue leading to inflammation, ectopic fat deposition, metabolic associated liver disease, inflammation, oxidative stress, insulin resistance, vascular dysfunction, hypertension, dyslipidemia, ultimately leading to atherosclerosis, myocardial remodeling, fibrosis, cardiac dysfunction, and glomerulosclerosis, neurohumoral activation. So they are all interconnected syndromes. So the sociological framework of CKM syndrome, cardiovascular kidney metabolic syndrome, in the management we have to take the individual predisposition, comprehensive management of the MAFLD, behavioral changes, relationship, community, social factor. So we have to deal with the patient as a whole and the social and environmental factors. So possible mechanisms leading to cardiovascular disease in patient with NAFLD, there is increased atherogenosis associated with metabolic associated fatty liver disease leading to cardiovascular disease. So the CKD in cirrhosis, diagnostic evaluation, evaluation of cause of CKD. Try to determine the cause of CKD by good clinical history, physical examination, review of the medication chart, symptoms, signs of systemic disease, and symptoms and signs of urinary tract abnormalities, social and environmental history, family history of genetic disease, and then the laboratory test that will see genetic counseling if required. So we have to look for the risk factors of NAFLD, type 2 diabetes, genetics, obesity, NPLA3, ethnicity, insulin resistance, dyslipidemia, metabolic syndrome, and secondary risk factors, age, gender, family history. So the non-NAFLD, we have to take a detailed history. Then assessment of renal function in cirrhosis, estimation of GFR. Mostly the creatinine definition of the acute kidney injury, chronic kidney disease is based on the creatinine-based GFR. But we know that the creatinine is reduced in cirrhotics because of the reduced formation secondary to muscle wasting, reduced creatinine synthesis in the liver, increased renal tubular secretion of creatinine, increased volume of distribution, and underestimation of serum creatinine by hyperbilirubinemia. Therefore, the serum creatinine-based equations overestimate GFR. And the measurement of urea, there is reduced protein metabolism and BUN generation secondary to liver disease. So serum creatinine of 1.3, it depends upon the muscle mass. Therefore, 1.3 creatinine, young man, GFR is 100 ml, while in older woman, same serum creatinine 1.3, the GFR is 50 ml. So therefore, novel biomarkers in cirrhosis, cystatin C, NGAL, etc., But the new cystatin C is considered better, but it has not been, the upper limit has not been validated. It is not widely available, and it is increased with hypoalbuminemia and in presence of infection. Then NGAL is very good marker, but increase in CKD, infection and liver disease. So upper limit is not yet standardized. So the ideal biomarker, the search is still on. And we should know that the markers, serum creatinine, cystatin C, are the markers of filtration, while the NGAL and other biomarkers, they are the markers of injury, which are present when there is structural or acute tubular necrosis, and not present when there is functional kidney disease. Therefore, serum creatinine is still established, inexpensive and simple biomarker till we get ideal biomarker which is readily available. So does urine examination improve diagnostic value? Urine examination is very important. It should be sent on admission. When we are writing other investigation, we should write urine examination also. And serial urine microscopy for urinary sediment revealed diagnostic findings in acute tubular injury, otherwise not identified by the single examination. So the functional versus structural AKI, as we have seen that the urinary cell biomarkers in functional, they are within normal limits, while they are increased in structural kidney damage. So the assessment of renal function in cirrhosis, duplex Doppler ultrasonography is very important, and it gives the renal vasoconstriction as a marker for functional disease. You know, the renal duplex, in the presence of HRS, there is Doppler sonography reveals reversal of diastolic flow and absence of end diastolic volume. So it is very helpful in indicating renal vasoconstriction and functional kidney injury, HRS. So what is the difference between functional and structural CKD? When the functional kidney injury is present, that is responsible to vasoconstrictors and albumin, while the structural does not respond. So the risk factors are mostly present in the structural kidney disease. Biomarkers are mostly present in the functional CKD. So it is important because that may respond to terlipressin albumin. So the management of CKD in cirrhosis, prevention is the best cure. For prevention of acute kidney injury is very important. Prevention is better rather than treating acute kidney injury, which can progress to chronic kidney disease. So anticipate, prevent and treat acute kidney injury very efficiently. Identify and promptly treat the precipitating factors, infection, GI bleed, nephrotoxic drugs, correct volume depletion, but avoid volume overload. Volume overload is associated with poor prognosis in acute kidney injury, treatment of a specific cause of acute kidney disease, because acute kidney injury is not a single entity, it's a spectrum of disease. Multiple factors may be involved. So in HRS, terlipressin, albumin, correct electrolyte and acid-base disturbance and drug dose modification as compared in relation to GFR. Conservative management, perform thorough medical review. Review treatment chart to look for nephrotoxic and hepatotoxic drugs, because we are dealing with hepatotoxic and the kidney and liver disease. Acute interstitial nephritis is very common, maybe superimposed on acute kidney injury, and in a biopsy series, antibiotics were found to be cause of 49%, proton pump inhibitor and NSAID, and top 3 individual drugs were omeprazole, amoxicillin and ciprofloxacin. And PPI may be associated with granulomatous interstitial nephritis. So drugs are causing a lot of problem. You should review the medication chart every day, even one time in the ward and 2 times in the morning, evening in ICU. Review the treatment chart. So what are the challenges associated with managing cirrhotic patient with CKD? The resistance or intolerance to diuretic therapy. Diuretic may precipitate AKI. There is growing concern about beta blocker therapy in such patients, avoid in decompensated liver disease. There is very high rate of hepatic encephalopathy following TIPS, and requirement of large paracentesis, large volume is often high because of rapidly accumulating ascites in these patients. Poor tolerance of hemodialysis, Dr. Chandni will tell, and compulsory avoidance of dose modification of several concomitant medications. There may be interaction and difficulty in deciding between liver versus SLK in these patients. So reduce the risk of progression of chronic kidney disease. Once the CKD has developed, how to reduce the progression? Lifestyle modifications are very important. Healthy diet, physical activity, stop tobacco, weight management. Then first line management, SGLT2 inhibitors, and manage hyperglycemia, control of diabetes, control of blood pressure. Then newer drugs have come, SGLT2 inhibitor, MRA that we'll see, calcium channel blockers, and then statin-based therapy, control of hyperlipidemia, antiplatelet agents. Always cardiac evaluation must be done in chronic kidney disease and treat it accordingly. Manage obesity and hyperlipidemia. Guideline-directed therapy, SGLT2 inhibitor, GLP-1 receptor agonist, RAS inhibitor, and non-steroidal MRAs. SGLT2 inhibitors propose cardiorenal effects. They reduce systolic blood pressure, reduce arterial stiffness, and reduce intraglomerular hypertension, leading to reduced proteinuria and slowing the progression of the kidney disease. So it is now very frequently used drug, but we have to tell the patients, now if the patient develops symptoms of urinary tract infection, he should stop SGLT2 inhibitor for some time. And if the patient has fever, vomiting, hypovolemia, hold SGLT2 inhibitor. Beneficial effect of MR antagonism, finerenone. So in chronic kidney disease, there is hemodynamic changes which are treated by the ACE inhibitor ARB. Then vascular changes, SGLT2 inhibitors are effective. And then there are chronic inflammation and fibrosis. So the beneficial effects of MR antagonism like finerenone is effective in prevention of the progression, chronic inflammation and fibrosis. But with finerenone, you have to be very careful about hyperkalemia. And all GLP-1 agonists, they are very helpful in hypertension, diabetes, control of cardiovascular disease. Newer drugs in the pipeline, aldosterone synthase inhibition, endothelin receptor inhibition. So the way forward, comprehensive approach to the potential targets of modulating intrahepatic and vascular resistance in NAFLD by lifestyle modification, statins, vasodilators, antibiotics, rifaximin, and multi-kinase inhibitors, antioxidant, FXR agonist, and AA pathway inhibitors, and anticoagulants. So a comprehensive approach, molecular biology approach is required. Then transplantation, the dilemma, whether liver transplant should be done first, or the kidney transplant should be done first, or SLK should be done. So what are the indications of SLK? Sustained acute kidney injury, when the GFR, kidney replacement therapy is required for at least more than 6 weeks, GFR is less than 25, then or above combination of these factors. Chronic kidney disease patient is already on maintenance hemodialysis, GFR is below 30, or metabolic disease, hyperoxaluria. We have done SLK in a child with hyperoxaluria. And there may be other metabolic disorders, atypical hemolytic uremic syndrome, familial non-neuropathic systemic amyloidosis, and methyl malonic aciduria. ILBS data, spectrum of liver disease in end-stage kidney disease patients, January 23 to July 24. The CKD incident, those who received first-time hemodialysis, 221 cases, and the current maintenance hemodialysis patient, 102 patients, and combined 323 patients. Hepatitis B virus, 7.4, SCB 10.2, MFLD in around 20% patient, compensated CLD 9.5, and decompensated CLD in 7.7%. So these B and C cases, they were all receiving dialysis outside. In our unit, in last 12 years, not a single patient has seroconversion. Gender-wise distribution of NAFLD patient, male preponderance, and the rising trend of NAFLD, and the NAFLD associated with diabetes, obesity, and hypertension. So the take-home message, anticipate and promptly treat AKI. Risk of developing CKD is higher in patients with severe or repeated episodes of AKI. HRS AKI can occur in patients with underlying CKD. Prevalence of CKD in cirrhosis is rising due to rising prevalence of diabetes, hypertension, obesity, and MAFLD. NAFLD patient look for CKD, and in CKD patient look for MAFLD. Without cirrhosis, without decompensated cirrhosis, NAFLD patient can still have low GFR, so look for renal dysfunction. The need for less invasive methods to measure portal pressure for functional stratification of patient with NAFLD. As I told that subclinical portal hypertension, HPPG between 5 to 10, these patients may also have chronic kidney disease, renal dysfunction. So we have to develop some non-invasive system to measure portal hypertension. And urgent public health education is needed to prevent the rising burden of MAFLD and CKD, because both are epidemic now. Then there is a groundbreaking initiative by ILBS, a Herculean task by Professor Serene, the integration of MAFLD into national program. India is the first country to do this. The layman's concept of organ crosstalk. Then protect your liver to save your heart and save your kidneys. Thank you.